This is Tom Lee, editor-in-chief of NEJM Catalyst, and we're talking today with Eric Makaitis, the CEO of Cook County Health in Chicago, about a topic that matters deeply to senior leaders, board governance. And we're focusing on the specific topic of how to engage the board in quality and safety when there are so many other issues that can easily dominate their attention. Eric brings two special perspectives to this topic. The first one's common, the complexity of the structure and therefore the governance of Cook County Health. The second is not so common. Eric's role before becoming CEO was Chief Quality Officer, so he really cares very deeply about this topic and presumably wants his board to as well. So Eric, let's start by helping the audience understand Cook County Health today.
Absolutely. And Tom, before that, I just want to start by thanking you for having me on this podcast and giving me the opportunity to share some of the great work that's happening at Cook County Health. So I'll just start with some background about Cook County Health. We are an almost 200-year-old public safety net health system operating in Cook County, which includes Chicago and its surrounding suburbs, and it's the second most populous county in the United States. We're comprised of two acute care hospitals. We have Stroger Hospital in the Illinois Medical District, and then Provident Hospital on the south side of Chicago. We also have over a dozen ambulatory sites across the entire county. We provide healthcare to our Cook County Jail and Juvenile Temporary Detention Center patients. And something I think that makes us very unique, we also oversee the county's public health department and the county's largest Medicaid managed care plan called County Care. Our mission is to provide universal access to high quality healthcare and services to all Cook County residents, regardless of ability to pay, with the goal of ensuring that everybody can live their healthiest life. We also have an incredible legacy of medical education and innovation. Cook County Health is home to the nation's first blood bank, first medical residency program, and first comprehensive trauma unit. We currently have about 440 trainees in various residencies and fellowship programs, and we're the largest single-site internal medicine residency program in the United States. And fun fact, if you've seen the show ER or the movie The Fugitive, you'll be at least a little bit familiar with Cook County Health, as both of those were set in the old Cook County Hospital.
Well, you can certainly understand why I described your organization as complex. What are the implications for the system board structure when you have so many different entities and they're naturally going to be focused on their own issues, plus a political entity, the county? It sounds like the risk for everyone on the board thinking about priorities other than those of the system are very high.
Absolutely. And as you already said, it's very complex. Beyond the independent health system board, we also have our county board of commissioners, which is led by the county board presidents. And they're responsible for appointing our new health system board members whenever needed. And then internally, as I alluded to just a bit ago, the various divisions, the hospitals, the ambulatory team, our public health department, the care at the jail, our health plan, it was really difficult to get line of sight to all of the moving pieces in just one health system board subcommittee meeting focused on quality. Another complexity is being government run. We are governed by the Open Meetings Act. So our board meetings are actually public and are live streamed, which poses an additional challenge around how much information we can actually share during those open meetings. We've committed to being transparent with our board, though, so we've had to think about different ways in how we can engage them, one of which is when appropriate and compliant with the Open Meetings Act, we go into closed sessions to be able to share some of the more sensitive information. But to have a more consistent cadence, we've actually developed now divisional quality governance committees.
So the first step, I would assume then, is getting clarity among all these different players on what the system board is supposed to do.
Definitely. So we put structure and some rigor around that. We have been very fortunate to have the support of both our health system and our county boards in maintaining our momentum around quality and high reliability. We embarked on an operational excellence restructure when I joined Cook County Health as Chief Quality Officer. And the focus was to bring in new tools, leverage A3 thinking, create a catch-ball structure to facilitate discussions at the strategic level between our senior leadership and our board, and then have those conversations cascade out to our directors, our managers, our frontline teams, so that we can ensure accountability and oversight for quality and safety outcomes at every level of the organization. Another piece was having the board engaged in that type of a conversation allowed them to support the adequate resourcing and allocation to support safety initiatives and ensure that patient safety was clear and visible, and that it was a shared concern across the entire organization, which I think actually pulled through all the way to our patients, our families, and our communities, even beyond our staff.
Well, knowing that your board really does feel responsible for ensuring adequate resource allocation for the priorities, that's obviously a huge accomplishment to pull off when you've got such a complex structure. Let's turn to the topic that I know is closest to your heart, quality and safety. And in this complex structure, how do you go about making sure that that gets the attention it deserves? Who are the board members and how are they picked?
Yeah, so I'll start with the second part first. So we have a separate nominating committee that sends recommendations to our county board president. She then forwards her nominees, the ones she chooses, to the county board, who then ratify the placement of those candidates onto our system board, onto our health system board. So that current board is actually comprised of a mixture of healthcare and non-healthcare leaders. And the board members who do work in healthcare also have a wide range of backgrounds, including payer and public health experience, leadership roles in FQHCs and consulting and behavioral health. And then we have a handful that have more kind of traditional clinical roles within other organizations. And then to the question about keeping discussions at the system level, that development of the quality operational excellence, that catch-ball structure that I referred to earlier. Now in my current role, we've actually extended that into our broader strategic planning structure. So it's across our entire strategic plan now, where we're trying to ensure that we are having the right conversation, the right altitude of the conversation, so that when it's senior leaders discussing with the board, we're focusing on system level strategies.
Well, I've been asking my questions from the perspective of someone who identifies with you and is rooting for your success in pulling everyone together and working for the goals of the system. But there are the quite legitimate perspectives of the entities within your system. How do you go about ensuring that they feel represented and heard, and also feel that it's in their interest to be engaged in the system's goals?
So I think applying the operational excellence structure to our broader strategic plan has really helped. We focused on keeping the discussions at the right altitude at every level of the organization. For example, system-wide strategies are discussed at the board and the senior leader level. And my feeling is that the senior leader over each division should really see themselves and understand their role and their team's role in each system strategy. So it's not the other way around. We had a lot of discussion around this, where we had we were calling out specific entities at the system strategic level, and we kind of turned that on its head a little bit and said, well, we should be framing this as a system-wide strategy, and each division should understand and see themselves, understand their role and really see themselves within each system strategy. So, as an example, we may think about setting a system strategy that focuses on achieving high quality outcomes. And our hospitals might identify that central line infections are an opportunity. So at the division level, at the hospital level, they might start looking at CLABSI rates. Whereas you then cascade out to the units, and they may focus on reducing line days, and then our frontline teams would focus on daily bundle compliance. And I think the key here is, as you implement that catch-ball structure, we're using the strategy deployment to really create the top-down side of the cascade to be the what, that we're saying what we should work on. We're providing that strategic direction. And then the bottom up, the cascade back up, is how, right? I think back to some of the early work that we did in sepsis here and improving our performance. We realized quickly that senior leaders aren't going to really grasp or understand the complexities or the challenges that somebody at the bedside is experiencing, and how to improve our response to a septic patient. So that was one of the first times that we really tried to implement that, in having that system level strategy, understanding sepsis response needs to be a priority, and then empowering the frontline teams to tell us how to do it.
Well, the bidirectional flow dynamics that you described really are quite impressive. So let's go a little bit deeper and talk about the quality and safety as a governance focus. Can you go a little into more detail about how you structure things?
Sure, sure. So, we had a big expansion as we kind of grew this operational excellence structure, specifically within quality and patient safety. And the volume of information that was being reported to our quality and patient safety subcommittee really grew. And we didn't really have a venue to engage each division's leader and deep dive into the work that's happening within each team. So we created the quarterly quality governance committees in each of the divisions. And in those meetings, we had one member of our QPS, Quality and Patient Safety board committee members, and then a non-QPS board member paired up and then assigned to a division. So those pairs, along with the systems quality team, then started meeting with the division's leadership and the leadership team to review divisional quality and safety metrics, creating kind of a venue for a more in-depth discussion around the unique challenges and opportunities for each of the divisions. This also allowed the board and each facility to develop, I think, a more meaningful and productive relationship with each other. Promoted, I would say, a constructive and bi-directional flow of information.
Well, I'm not surprised that you're making sure that quality and safety are prominent on the board agendas in this way. Can you give an example where the experience of your board is actually helping the organization?
Definitely. We had in fact, the chair of our quality and patient safety committee recommended a platform that we're in the midst of implementing right now. And it, I thought was very intriguing. It leverages AI as an overlay on your EMR, and it helps identify population-specific interventions based on real time regarding it calls the patient demographics and then gives real-time feedback. So as an example, U.S. Preventive Task Force Services recommends prostate cancer screening at 55. However, now some of the leading recommendations in the Black population is that it really should start 10 years before that. And when you unpack the studies that informed the task force recommendation, they were mostly done in white populations. So it calls out those potential issues around not just health equity, but sometimes implicit bias as well, right? So we're excited to really kind of get that going and have that there as a tool. But that's an example of some incredible value that our board provided to say, hey, we're focusing on these concerns, these issues. Have you thought about this, right? So giving some guidance, giving some opportunities there. And again, in the spirit of that bidirectional information flow, our quality team also started building educational and informational sections into those quarterly patient safety reports that highlight various research topics or emerging trends in safety and quality so that the board members stay informed around new developments and they understand their impact on Cook County Health.
So, how's it going overall? How is quality and safety at Cook County?
We're seeing some pretty exciting and promising trends. So Stroger Hospital has improved its CMS star rating from 1 to 3 stars and also improved Leapfrog safety ratings from an F to a B. We've now been a B for 5 measurement periods, and we're just shy of that A. It's less than like half a point from the A. So we're hopeful we'll be there soon. Provident Hospital was also recognized by Leapfrog as a top general hospital this last year, and our health plan is an NCQA 4-star plan, which ties them for first place for MCOs in the county. Our employees have also scored exceptionally high for questions related to how the organization is actively improving patient safety. More than 70% of our staff indicated that they feel that they're able to raise workplace safety concerns without fear of retaliation. We've also been recognized by several agencies, including Press Ganey, over the last year or two. Several clinical programs have also been recognized by the U.S. News and World Report for best-in-class performance in key areas, including clinical outcomes, levels of nursing care, and patient experience. And I think this last piece is what I'm most excited about. Our most recent survey with Press Ganey for employee engagement showed an incredible improvement both in survey response rate and overall performance. The response rate improved by 10%. So for us, that meant an additional 500 people who engaged in completing the survey. And the overall score jumped by 14 percentile points nationally. So I'm hopeful that that last piece is an indicator of improving engagement, a bit of maybe culture change, one that's going to focus around safety and quality and continue to drive improvement.
Well, Eric, I want to thank you for the work that you're doing, first and foremost, and for sharing your insights on governance in one of the most complex organizations in the country. And I'm going to congratulate you on the work that you and your colleagues are doing on quality and safety at Cook County Health. We are all rooting for your success, and we're hoping to learn from the way you accomplish that success. And I am confident that we'll be talking to you again or reading words that you and your colleagues have written before long. So thank you very much.
Thank you, Tom. Thanks again for having me.